Good morning, and thank you for joining today's briefing on our new report, Successful Transitions, Reducing the Negative Impact of Nursing Home Closures. I'm Lori Smetanka, Executive Director of the Consumer Voice. We undertook this study a little over a year ago with support from the Retirement Research Foundation because we've been seeing an increase in the number of nursing home closures due to both voluntary and involuntary reasons, and because we're also seeing a negative impact on the residents of those facilities that are closing that can be very significant if they're not managed with the residents' rights and interests at the forefront. Leading us through the briefing today is Cynthia Rudder, our project's principal investigator. Dr. Rudder has a long and distinguished career of research and advocacy on long-term care issues, and we're thrilled to have been working with her on this project. Very quickly, before I turn it over to her, as you heard, today's briefing is being recorded. All participant lines will be muted throughout the webinar. Any questions can be submitted in the question box on your webinar control panel, and after the presentation we'll get to as many of the questions as we have time for. So now I'm going to turn it over to Cynthia to lead us through the study, the findings, and the recommendations. Cynthia?
Hello, good morning everybody. Thank you so much for joining us. As Lori said, the reason I got very involved in this project is there was a disastrous closing in New York State a few years ago where residents were sent hours and hours from their family. And I became interested in what was happening across the country, and we began this study. The goal of the study was to make recommendations to lessen or eliminate the possible negative effects on residents of closure. We began by trying to identify the current obstacles to what we considered would be an implementation of a well-planned resident-centered discharge planning when a nursing home had to close. Clearly, we never really wanted nursing homes to close if there was any way to keep a nursing home open and keep the quality of care high. But in those cases where a nursing home was going to close, we wanted to look at the obstacles to having a closing that was at least somewhat beneficial for residents and dealing with the potential negative effects. And then we wanted to identify policies, procedures, and action, ways to overcome the obstacles. Then we thought about looking at whether there were best practices around the country. Are there any states that were doing some best practices to try to ameliorate the potential negative effects? And then, of course, to translate the findings into a report, which we've done, with materials and resources for you in order to help you get some ideas to ameliorate the potential negative effects of closing. We used online surveys, interviews. We then made some case studies with 3 practice states, and I'll talk more about that in a little bit. And we also decided to write up a case study of what a poor practice closure was, to look at what happened in those instances. This gives you some idea of some of the people who responded to our surveys and our interviews. We also got information from 6 survey directors. While we're not trying to generalize it all from 6 survey directors, because there are 52 in the country, it was interesting to us to at least see what these 6 survey directors had to say. The interviews, you can see who we interviewed. The interviews were people who agreed to be interviewed from the survey. The survey was anonymous, and so those who agreed to be interviewed put their name down, and we responded to them and spent about a half hour to an hour on a telephone interviewing these specific people. This tells you again some of the interviews that we had. When we did the best practice case studies, we looked at 3 states and did a lot of interviewing with some of those, and when they got some people in those states, and then got some information on other states. I'd like to talk now about the findings. There's a lot of findings in this study and a lot of recommendations, and I'd like to talk really specifically about some of those. Excuse me. The first thing that most people said was they had to stop involuntary closures before they became necessary. And people were very angry about the fact that providers seemed to get away with so much, at least in their opinion, and that facilities who give poor care feel they're never going to be terminated, they're never going to be closed, and so they keep going on and on until the point where the federal government or the state closes them or terminates them from participation in the Medicaid, Medicare program. And many people felt that you had to stop this really before it got to that stage. And these are just some quotes that people made that I thought would be interesting to look at. Another finding was clearly, and we kind of knew this, but we had to get it from the people who were responding, is that nursing home closures are problematic for residents. And here are some quotes that we got from our study. Resident belongings being trash bagged up with no labels as to whom it belongs to. Moving day chaos. Families not knowing where residents are moved. One local ombudsman said that the closure was one of the worst experiences of her life. I assume it was also one of the worst experiences of a resident's life as well. These are some of the other findings. Generally, people felt that voluntary closures went more smoothly. Some people found problems with voluntary closures because they felt that in some voluntary closures, and voluntary closures are where the owners or the boards decide to close the facility for financial reasons, or sometimes because they know that the feds or the state are going to go after them anyway, so they might as well try to close. Some people found problems even with the voluntary closures because if there were financial problems, staff leaves, there aren't enough staff to take care of residents, and the owner wants to get out pretty quickly. And a few found that involuntary went more closely. An involuntary closing is where the feds or the state go after the nursing home and terminate them from the Medicare Medicaid program, or a state removes the license. Most people found that the involuntaries were the most serious, had the most serious problems, but a few did found that the involuntary went more smoothly because in some states, when there's an involuntary closing, the state licensure and regulatory arm pay close attention. And that was only in a few cases. Many of our respondents felt that the success in the voluntary closures included ombudsman involvement, accurate information, and good discharge planning. Those were the three things that people felt were needed to have success in a voluntary closing. There had to be good facility discharge planners, residents and families had to be informed, and you can see some of the points there about the findings. This is a table showing what would be the criteria for success in a voluntary. This is the table. We only asked people who had experience in actual voluntary closures to respond to this question. And you can see that, again, the most important factor was the ombudsman had to be notified and had to be active in the closing. Another big issue was at the bottom of the table, you can see residents and family members were notified in writing at least 60 days prior to the facility closing. And you can see some of the other ideas. We looked at things that were basically over 70%, and you can see residents and families were kept informed during the whole process. They were given information on alternatives, and you can see some of the ideas that came out from the respondents. When an involuntary closure was successful, the participants felt that that was really because of the participation of the ombudsman and proper monitoring by the state. Those were the two things that the respondents felt made for a success in involuntary closures. Some of the other findings were that the respondents felt there had to be better requirements for closure, more provider accountability, and better state or independent monitoring was needed. People felt that the state should be more proactive, that they should hold regular meetings with all agencies, programs involved. They should be more proactive. For example, if special equipment is needed, the state should assist. And what they meant by that was, if a closing facility had bariatric residents that other facilities didn't want to take because they didn't have the equipment, the state should go out of its way to maybe make sure that the receiving facility or the facility the resident wanted to go to had the equipment it needed to care for them. That's what they meant by proactive. And that the state should demand that nursing homes that have vacancy accept their fair share. And we'll talk more about that in a recommendation we have, because one of the major issues raised was a lack of either vacancies in the area or facilities just didn't want to take certain people from a closing facility. And this is a table showing the 6 obstacles to a successful closing, whether it's involuntary or voluntary. These were the obstacles. And there were things like, again, lack of accurate communication. That came up over and over again. Lack of timely notice, over and over again. The biggest one, again, as I said before, was lack of available alternative placements in the community. That was said over and over again as the most important obstacle to a successful closing. And then, of course, poor discharge planning. Residents don't know their rights. A lack of staff or staff anxiety. And then transfer trauma. That's what came out from many, many ideas of the 6 most reported. We're going to take one of these obstacles one by one, and I have some quotes here that I thought were interesting just to show you what some of the people were saying about some of these 6 obstacles. The lack of appropriate nearby placements, the #1 obstacle. This is a mother that I interviewed who told me that her daughter was transferred 3 hours from her home. She, by the way, was called 1/2 hour before her daughter was transferred. She couldn't even get to the facility to say goodbye. She didn't see her daughter for 2 years. She only spoke to her on the phone. I will tell you that advocates in Rochester, New York worked hard to get this woman back to her mother's area, and she is now in the area, fortunately. The second obstacle, poor discharge planning. Here's an example. So we have anecdotal evidence and we have qualitative evidence. Residents were not told they had choices. Several residents were transferred to a sister facility, which was purchased by another corporation. Lack of communication. This is actually a resident in a Midwest facility who told me that she didn't know anything until she saw it written up in the papers. Residents were rushed out. Facility staff didn't even help her. Her medical records and medication records were not sent. She didn't have her medication for 10 days. Poor notice and not enough time to find placements. If staff is worried about their paychecks, they're now worried, can they give good care? If they're worried about whether they're going to get another job, if they're nervous, what happens to the care they're giving as the facility is closing? Transfer trauma. This was a major, major issue and was raised, and we'll talk a lot more about that in our recommendations. This is a local ombudsman who said she was working with a resident who's legally blind, and now he's in a new facility. He has to learn new ways, and what's happened, of course, is that his level of activity has decreased because the new facility is so afraid he'll fall. We also asked participants about the role of the state, and you can see this is the local ombudsman and state ombudsman responding to this question. There are some slight differences between the state and local ombudsman, but the role of the state, one of the most important things that were raised by the state ombudsman, is that there should be regular meetings with all the agencies and programs in the state to ensure coordination. Another big issue was establish an easy way for residents and their families to report problems related to the closure. State Ombudsman also said that the role of the state should be to reach out to nursing homes that have vacancies and try to help solve any problems like moving equipment for bariatric residents from one facility to the other. The local ombudsman had a little bit of a different take than the state ombudsman in that same issue. They should require nursing homes that have vacancies but are refusing to admit a resident to document why they cannot. Many of the state ombudsmen agreed with that, but it was much more raised by the local ombudsman. Local ombudsmen thought that the state should be on site frequently to make sure the transition is successful. Over 80% said that of those who responded of the local ombudsman. Only a little over 40% of the state ombudsman felt that. And that may be a difference because the local ombudsmen are always right on site during the closing. Actually, the state ombudsman thought that the state should be on site daily, which is kind of interesting. So what I just said doesn't quite, there's a little bit of a conflict there, but I guess the local ombudsmen think they don't have to, let me take back what I said. I guess the local ombudsmen may feel that because they're there, the other part of the state doesn't have to be there every day, but should be frequent, whereas the state ombudsman thinks that it should be daily, or many more of them do. Now, as I said before, we did get 6 survey directors to participate. We wrote a new survey. We sent it out over and over again through their association directly, but we only got 6 people to respond. But I thought it was important, even though we can't generalize, to at least talk about what some of these people said. One of the things that was very disturbing was at least these 6 survey directors, or 4 of them, felt that they didn't find any problems. They had no unsuccessful closures in their states, none at all. They felt that transitions were successful even if residents and families were not happy about their new placement. We also found that of these 6, when we were asked them what the role of the state was, they gave different answers. One of them saw the role as a facilitator of information, others saw their role as hands-on. And we'll talk more about that when we talk about the recommendations we make about what CMS should do about trying to get uniformity among the states of what their role is. We then looked at 3 best practice states, and I'm not going to spend a lot of time on this, but in our full report, you will notice a full case study on each of these states with contact information, telephone numbers, and emails that you can, if you're interested in, contact these people. They said they're very happy to share what they do. Now, all 3 of these states, we picked, by the way, there are many states, a number of states in the country that have best practices, but we picked these 3 because they had somewhat different best practices that we wanted to highlight. Now, all 3 of these states developed and continue to improve their systems by bringing together several state agencies to focus on nursing home closures. They had what was called relocation teams. So, for instance, Wisconsin brought together a work group consisting of the State Ombudsman, Division of Long-Term Care, Department of Mental Health and Disability Rights, to look at ways to improve the system. The Connecticut Long-Term Care Ombudsman Program convened a closure response coalition and brought together a number of agencies in Connecticut, and their mission was to develop a protocol to protect residents' rights. And then Ohio actually began an examination of their systems by holding a major retreat with a Kaizen event. A Kaizen event is kind of a Japanese word that brings people together to focus on the mission and the philosophies. Looking at Connecticut is only dealing at this point with voluntary closures where the facility wants to close. Some of the interesting things that we consider best practices is Connecticut can actually deny a closure to an owner who wants to close it if it finds it's not in the best interest of the public need and other state considerations. And in fact, though it hasn't used it very much, it's used it only once, I asked the state Medicaid director, well, what happens if you tell a facility that it can't close? He said they either are forced to sell it at a loss or they have to turn the keys over to us. That's kind of astounding that the state can actually think about what are the needs of the state in refusing a closure. It is clear that Connecticut does want to close nursing homes, the Medicaid people, in order to save money, put people in the community, but they still have this in their statute, and it still is a wonderful piece that allows at least advocates to fight for the needs of the state. And in the one closure in Connecticut where this was used, it was used because legislators got involved, the union got involved, advocates got involved, fighting to have this nursing home stay open, and the state refused to let it close. In Connecticut, the state requires a public hearing before it can make a decision to approve or disapprove a request to close. Again, though this isn't perfect, it does allow advocates to come up and talk about why a nursing home should or shouldn't close. It allows residents to speak, and it puts some pressure on the state in terms of closure and the facility itself. The state of Massachusetts has also recently passed a public hearing requirement. It also has a new statute that mandates that the state ombudsman send a notice to all residents. At the same time, the provider applies to the state for approval to explain the rights the residents have. Thus, they get their residents at the same time. The state ombudsman of Connecticut fought for this law because she found that once the facility sent a request for closure out, the rumor mill started, and when she finally got to the nursing home to even see what was happening, most of the residents were already gone without knowing their rights. Connecticut also has laws allowing residents to waive waiting lists if the facility that they want to go to does not have an opening. It also, a vacancy, if the facility has a waiting list and the resident wants to go there from a closing facility, it can. It also has a law that allows a resident to go to an interim facility, and when a vacancy opens up in the facility they want, they can go there if the facility accepts them. This is all in statute. Wisconsin has put all its closure rules in statute, which gives residents more protections. It has created in statute a relocation specialist within the state ombudsman office. And this individual functions even when there's, let's say, a renovation and 5 or more residents are moved. And he oversees all closures in the state. It has developed a relocation team comprised of state agencies. It has held lessons learned meetings to discuss what it's learned. Time to transition depends on the facility's census. If there's more than 120 people, if there's more than 50 residents in the nursing home, they can close for 120 days. And one of the major issues in Wisconsin is its focus on transfer trauma. Its manual has wonderful ideas to ameliorate the issue of transfer trauma for both the receiving facility and the closing facility. And I urge you to read these case studies. Look at all the resources in the appendix of the study. Will give you some ideas for fighting for certain things in your state. Ohio focuses on involuntary closures at this point, and they do have some voluntary, but I'm talking now about the involuntary. They also created a resident relocation team, but what's interesting about their team is that they meet even when a home is not closing. So they communicate and develop solutions to problems. For instance, an issue of transfer trauma came up recently about 6 months ago, and they decided to bring a group together to focus on transfer trauma. They also do advance work long before a nursing home is forced to close. When the facility is in danger of being terminated from Medicare and Medicaid programs, they then start to work. Even though, as we know, most nursing homes are in danger of being terminated, come into compliance and are never terminated, they still begin the work with those facilities anyway. They go in there and they speak to, without mentioning closure, so they don't want to get anybody upset because the facility may come into compliance and not close. They begin speaking to residents. They see which residents might be able to live in the community. They give help for facility staff, and they do significant follow-up with all relocated residents. Again, take a look at the case study. We then sent out another survey asking people, how do we overcome some of the obstacles, those 6 obstacles that I talked about before? And I'm going to go through this fairly quickly. The full report gives pages and pages of ideas that people responding to the survey gave for overcoming these obstacles. I put them into broad categories, but there's a lot of wonderful ideas out there that I urge you again, look at the full report. So the first obstacle, that lack of appropriate and nearby placements. Some suggestions: give the receiving facility maybe a monetary incentive to take a resident, more fines, regulations, and oversight, and encourage the receiving facility to take hard to place residents. And some of the ideas were things like urge the receiving facility to interview the resident themselves. Maybe they think they can't care for them, they can. Have the ombudsman of the closing facility look at the records, make sure the records are up to date. Maybe behavioral symptoms of a resident that makes a receiving facility reluctant to take them maybe ended 6 months before. It wouldn't be surprising for a poor facility not to be updating their records. And many, many more ideas are in the report. The second obstacle, lack of communication, accurate communication with residents. Again, this issue, obtain participation of the ombudsman early, and then require new protocols and rules that talk to the things that we talked about before. Requiring that letter to be sent from the state ombudsman at the same time the owner does, or with the owner, making sure that accurate information is being given. The poor discharge planning, which was another obstacle, and you're not surprised that particularly in an involuntary closure, you do have poor discharge planning. So some of the suggestions were maybe to require an outside entity to conduct the discharge planning. Requires that the ombudsman can comment on a closure plan before it's approved by the state. Give ombudsman a list of all residents being moved, and promulgate new rules on how discharges are handled. So maybe there should be requirements only that a certain number of residents can be transferred on each day. Maybe you're not allowed to do 50 residents on one day. Think about rules that will better protect them and have better discharge planning. Staffing issues. This has to do, require and provide more training and education on closure issues. Make sure staff understand transfer trauma, are trained in transfer trauma. Also be sensitive to staff. Provide assistance and referrals for them for new jobs. And then promulgate new rules. The state should know how much staff are on each unit almost every day or hour if staff are leaving. Require that state have to supplement staff. Maybe there should be bonuses and severance pay to urge staff to stay until the facility closes. And again, the full report has many, many more ideas. Transfer trauma. Before the move, give residents more control over where they move. Have them do tours of the facility that they might want to go to. Wisconsin has that in statute, requiring the closing facility to help residents tour and see facilities. Prepare residents for relocation. Have staff go to the receiving facility from the closing facility to talk about the residents so that they're prepared for the resident to make it an easy move and to make it more, maybe set their room up in a way that they're comfortable. Maybe if roommates want to go together, help roommates go to the same facility so that they feel comfortable, they have some friends. After the move, assist residents in adjusting to the new location. Have ombudsmen go in to check what's happening. Require that the receiving facility do a transfer trauma assessment of the residents as they come in and as they adjust. Many, many more ideas in the full report. Poor notice, not enough time. And again, require more notice and put rules in statute. Maybe something like Wisconsin does, depending on the number of residents you have. If it's an involuntary and the feds or the state feel the facility has to close because of such poor care, require the state to either take it over, temporary management, or bring in a management company. The state survey's point of view. These are some ideas, again, these are only 6 state surveys. We didn't get information from all 52. So you can see some of these quotes here, particularly around the availability. I don't think government, the federal or state government can tell facilities how to run their businesses. The last one is kind of upsetting a little bit to me. CMS and the advocates are unrealistic about some of the residents and families, which are unrealistic, should I say scheming and manipulative and irresponsible, expectations for care in a certified nursing home. Wow, wow. CMS seems to err on the side of the residents only. Yeah, right. Okay. Additional ideas for overcoming obstacles from ombudsman, advocates, families, and residents. And these are some other ideas, but again, the full report has a huge amount of stuff in it. This whole provider is accountable. You know, I'm going to talk about this a little bit. I've been talking to CMS, and Consumer Voice has been talking to CMS, and also Department of Justice. How can you hold the provider accountable who doesn't follow the plan, who throws the contracts with the feds in the garbage? He's closing. What does he care? What does she care anymore? And we've talked about, well, how do you hold these providers accountable? And we'll talk about that in a little bit. Some of the suggestions, maybe Department of Justice can come in and look at whether and hold them accountable for civil rights violations related to discrimination against the disabled. And we didn't study that, but these ideas kind of came up to think about. Can you hold them criminally liable? Can you put liens on their property? States have to look at licensure rules related to an owner who does this in one facility. What about his other facilities? And these are some ideas from survey directors. I'm going to skip now to recommendations. We have about a little less than 10 minutes. We want to leave time for questions. I hope you're typing in your questions so that Lori can look at them all, and hopefully I'll have time to respond to your question. The recommendation for CMS, I'm moving to the slide that says general recommendation CMS. We think that all states should be required to develop a relocation team, as we've talked about in the study. This is what the best practice states have done and other states have done that made a big, big difference. When everyone is on hand, everyone focuses on it from all different angles. We think that all states should be required to share the closing facility plan with the state ombudsman before approval. We've heard situations where ombudsmen never even saw the closure plan. How can they even protect the rights of residents? Require states to develop a closure manual. Make available civil money penalty funds. Provide clarity to state licensing and certification agencies about their role. What should their role be? Hands-on? Hands-off? What should they be doing? For the first obstacle, we think that CMS should require that if a facility doesn't want to admit them, that has to document and send to the state the reason for this denial. They can't just say, I can't care for them. If the state agrees that the reasons for the denial are legitimate, it has to be proactive and first try to find a solution to the problem. Why aren't you don't want to take them? You don't have equipment for bariatric residents? You think the behavioral symptoms are too difficult? What can we do to make it easier so that you can feel comfortable about caring for the resident? But if it's a violation of civil rights, it should be reported to the Civil Rights Division by the state. Poor discharge planning. We think that independent people should be put in and the facility should hire a management company or apply for receivership, but you can't allow poor discharge planning to go on. And this is what we're urging CMS to do. For the third obstacle, lack of communication, require on-site monitoring by the relocation team. And CMS has to monitor state compliance. Important issue. They've got to make sure the states do what they're supposed to do. As many of you know, CMS put out guidance for closures. We think they shouldn't be guidance, they should be required. For notice, facility has to remain open until all residents transfer to an appropriate location of their choosing. It cannot close. If the state or CMS believes the facility must close, poor care, state has to take it over through a receivership or management company or temporary management. There has to be at least 60 days for an involuntary. As I said, there's no 60 days, there's only 60 days for a voluntary. The 60 days for involuntary, if it has to close, bring in that manager or the receiver. Here's some issues around staff leaving, staff stress and bitterness. State relocation team should focus on the needs of staff. Make sure that the facility closure plan includes ways in which the facility will make sure there is enough staff. Facility should report staffing on each shift. Require the state to hire additional outside staff, if necessary, paid for by the closing facility. Require transfer trauma. Require that the facility closure plan submitted include ways in which the closing facility will attempt to lessen any transfer trauma. And here are some ideas that come basically from the Wisconsin statutes and manual. And there's a lot of these ideas. It's in the full report. Take a look, and it's also in the manual of Wisconsin. These are more ideas about ameliorating transfer trauma. Here are some more ideas. Require receiving facilities to develop plans. Receiving facility staff should visit. Now, these are recommendations for states, and they're very similar to the recommendations we had for CMS. And I'll skip some of those that are the same because we only have about 4 minutes. I want to make sure there's time for questions. But you'll see where we want CMS to require states to create a relocation team, we're saying states should require a relocation team. If CMS doesn't put in our requirement, our suggestions, everybody in individual states should be fighting for some of these things. Posting on their websites all the requirements. Pass legislation to codify it so it's in statute. Develop a system for residents to file complaints about the closure. Introduce a requirement about a public hearing in your state. Introduce and pass laws permitting residents to be admitted to the first available bed like Connecticut has. Require facilities to document in writing the reasons for not wanting to accept. And some of these recommendations for states are things that come from the best states and also from the CMS recommendations. So I'm going to go through this because I want to make sure I look at the Ombudsman recommendations as well. But you see, coordinate discharge planning from an independent planner, all very similar ideas now on the state level. Require the closing facility to report staffing. Consider a tax on ownership licenses to fund a staffing account that might give bonuses to staff that remain until closure. Encourage them to hold job fairs. Now this is for the Ombudsman. One of the things we found that we were a little bit surprised at, even though most of the Ombudsman participants said that participation of the Ombudsman was the most important thing and being involved, We found that many of the Ombudsman participants did not know the rules, the federal or their state rules on closure. So one of the things we're recommending strongly is that all ombudsmen be educated on state and federal closure rules. The Consumer Voice has received a new grant from the Retirement Research Foundation based upon our findings to actually undertake education of ombudsmen and citizen advocacy groups in the country. And I know Lori will talk more about that at another time. But this was a major issue that we felt. If ombudsman is important for them to be involved, they have to understand some of these things. And they have to develop a formal written protocol for how they relate to the state and to the state ombudsman and other state agencies. My time is almost up on this, so before questions. But some of these ideas for ombudsman, again, come from all the findings. Recommend that ombudsmen check records of those being refused admittance to make sure they're up to date, as we talked about before. Urge refusing facilities to interview and assess the resident. Maybe an ombudsman might file a discrimination complaint with the Civil Rights Division if the state has not, and they feel there is a violation. And this is obvious, share information with the residents and families. Designate a member of the state ombudsman office as a relocation specialist to coordinate ombudsman activities, like Wisconsin has. Develop a letter for residents and families like Connecticut has. At the same time, the provider is even going for closure. Meet one-on-one with residents or families. And these are some of the other ideas. Advocate with the corporation of the closing facility for staff to be hired at sister facilities, if that's applicable. And many, many other ideas that again come from the best practice states or the findings of our study. Develop in-service training for staff on transfer trauma, work for facilities, on staff understanding what the transfer trauma is. Create a list of tips for what staff and family can do to help alleviate transfer trauma. Conduct follow-up visitors. Determine the facility's process for tracking residents' belongings to ensure they're moved. As many ombudsmen have done in the country, many of these things, but it won't work unless they know the rules, and they work with the state, and there is this big team working together. Well, that was in 41 minutes, a snapshot. It went very fast. I urge you to look at the full study, and I'll turn it back to Lori for any questions.
Great. Thanks so much, Cynthia. As you can see from the presentation, the report is really just chock full of not only really good information that we gleaned from the survey respondents, but also good suggestions for making the closure process better for the residents and offering suggestions for protections of residents. And it really is a multi-agency process in order to protect the residents as best as possible. I do want to share that the report, the materials from the best practice states are all available on the Consumer Voice website, www.theconsumervoice.org. And in terms of information from the states, they will include sample letters and closure manuals, brochures for residents and family members, things that the best practice states have been using in their states to help protect the residents. So you can type your questions into the question box on your control panel. So don't be shy. Type the questions in, and we'll ask Cynthia about them. A couple questions have come in. One is whether we've shared the report with CMS and what their response has been. And maybe I'll start with that, and then Cynthia, if you want to add anything to that. We have shared the report and recommendations with CMS and met with them about it. CMS is in the process of developing guidance around new closure regulations and are reviewing the findings of the report and the recommendations as they're developing and finalizing that guidance. And so we do hope that they will take the recommendations into consideration as they're finalizing that. And the report has also been sent to the licensing agencies. They've all been invited to the briefing today, as well as to ombudsman programs. Another question that's come in,
Lori,
sure, Cynthia, go ahead. Yep.
I just want to say that we shared this with CMS about a month or two ago when it was in draft form to make sure that they saw our recommendations as they were working on the guidelines. We knew we couldn't wait until it was sent out. We did an actual PowerPoint presentation for them, for Karen Trist and Evan Schulman and Jay Weinstein, who handle, as many of you know. So we really have worked very hard and follow up, urging them, and also with Lisa Tripp, who is somewhat the enforcement czar, I guess. And they've agreed all to look at it, and not only look at it, but they seem to respond to some of these ideas. We had a very full discussion. I just wanted to elaborate on that because it was very important for us to try to push this pretty hard.
Mm-hmm. Thanks, Cynthia. One of the questions that we've gotten in is how common is closure currently? And Cynthia, I know you had looked at some of the data around that.
Yeah, I can't remember the numbers. I had done a table. We never put that table in the report, Lori, I realized. But I had done a table, and I'd be glad to share that with people. It is becoming more common because of, obviously, states trying to urge people to get care in the community. It's what consumers want, and states think that it will be cheaper in the long run. And it's the whole movement, obviously, towards the community. It also is the concern about Medicaid payments, et cetera, et cetera. But it's not tremendous. But for instance, I think it was Ohio over the last year and a half had something like 22 closures. So it depends on the state. I'm trying to remember the numbers, and off the top of my head, I apologize. If everyone is interested, if you want to give them my email, I can send them the table we did and the actual numbers.
Okay, we can make that available to folks. Sure. From
CMS database of closures and why facilities were closing around the country. We've looked at that for the last 6 or 7 years.
Sure. And what we see, as Cynthia mentioned, while we're seeing an increase in closures for a number of reasons, the impact of a closure, even if it's one closure on the residents there, if it's not well done and the residents' interests are not put at the forefront of the process, can have very significant and negative effects on the individuals that are being moved, as you saw from some of the quotes that Cynthia listed at the beginning of the presentation. Very serious concerns. And so it's really critical that states and CMS have good processes in place for protecting the residents that are being subject to transfer or discharge as a result of these closures. Again, you can type your questions into the question box. One of the things that I wanted to mention is, sure.
May I say something? I just also wanted to raise that another issue around closure has just happened and may happen more. In New York City, a law company which owns a number of nursing homes in New York closed a nursing home without getting any approval. Of the law. And when the state came to do its inspection, it found the facility empty. And then the owner sold it for condominiums. He made a bundle. We are looking into this, what can be done about this. And again, this could be happening in other places where real estate is going up. So I urge you to keep an eye on that. We're very concerned of what do you do about that when they just close without any approval.
Right, that's a significant concern. Another question that came in, Cynthia, was whether the study looked at homes that closed due to weather-related or emergency situations. And while that was not a specific area that we looked at here, we do have information on that. We do have a report from several years ago around looking at that particular issue, and quite a bit of information around emergency preparedness and protecting residents, but that was not one of the areas of focus of this study. One of the, as most of you know, CMS recently came out with new regulations for nursing homes. They had updated the requirements of participation, and while they did not in those new regulations update or change anything related to closure, there are some new protections around the transfer and discharge provisions which would apply in closure situations. So for example, there are requirements in there related to providing choice and orientation and preparation for residents who are being transferred or discharged from a nursing home. And there are also specific requirements that are required to be sent to the receiving provider, whether it be a new nursing home or a new provider in the community, that must go with the resident in order to orient that new provider about the care needs and goals of the resident that's being transferred, and also to help with the orientation process as a means of reducing transfer trauma. So those are some important new protections that have come out since we undertook and released the report, and we think that those will be helpful as well. Cynthia, we don't have any other questions, so we'll just give them one more opportunity to type anything in that they may want to ask. And in the meantime, are there anything else that you'd like to share related to the report, or any last words?
No, I guess you can give people my my email if anyone has any specific questions that they think about after this. But I urge people to really look at the full report. Not only the recommendations, but look at what the as you said, the best practice states. But look at the recommendation for the states, and as you think about ways in which you might be able to fight for some of those things, and please feel comfortable in calling the people in the best practice states. They're very happy to speak to you. The full report also lists about 6 or 8 other states with other best practices, like Michigan, I think it was South Carolina, not in full case study as the 3 states, but do raise some other interesting best practices with contact information that you can call some of those people. So I urge you, and they have links to their manuals. So if you need ideas for your state, that's the place to go.
Great, thanks so much. And so we don't have any other questions today, but as Cynthia said, please look at the report. You can find it on our website. Cynthia, do you want to give them your email address in case they have specific questions for you?
Sure. It's C as in cat, R as in rat, N as in Nancy, H as in Harry, C as in cat, C as in cat, at AOL.com.
Great. Thanks so much. And we can also get messages to Cynthia if you wanted to contact us here at the Consumer Voice. Thanks for joining us this morning. Any questions that you have related to the report, we'll be happy to answer. As Cynthia mentioned, we just the other day found out that we will be able to do a part 2 on this project. We'll be sharing more information about that in the coming weeks, but we will be focusing on providing some support and education for ombudsman programs around closure requirements, best practices and ways that we can support them to support the residents that are facing these issues. So with that,
Lori,
thank you. Yep.
I'm saying we also want to invite some of the citizen advocates to those kind of things.
Absolutely. Absolutely. Cynthia, thank you for your time this morning and all your work on this report and this project. We look forward to continuing that work with you, and thanks to all of you for joining the briefing this morning. More information will be on our website about the topic and the report in the coming weeks. So thanks so much, and we'll close out for today. Thank you. Bye-bye.
Bye-bye.